So I would like to welcome you to the webinar of the Society on Liver Disease in Africa. The SOLDA is having this webinar on the occasion of celebration of the World Hepatitis Day. Hopefully we will be celebrating every year with a new success from the African continent. And there are several speakers from different parts of Africa discussing some successes and some challenges and gaps. Here is our program, Where Do We Stand in Africa? The patient's perspective on hepatitis B for the World Hepatitis Day webinar. From Southern Africa, we have a talk on hepatitis A virus in transition. From Southern Africa, we have hepatitis E in Sub-Saharan Africa, an emerging disease. And from Central Africa, we have a talk on hepatitis B and Delta, two heavy burdens on Sub-Saharan Africa. From Northern Africa, the story of success of Egypt on hepatitis C elimination. From Western Africa, we have prevention of mother-to-child transmission of hepatitis B and some success stories. And then we will have the questions and answers and then the closure of webinar. And we would like to encourage you all to either raise your hands or send your questions in the chat so that it will be a fruitful discussion. So SOLDA currently is a sister society with the American Association for Study of Liver Disease, the Latin American Association for Hepatology, the APASL, the Asian Pacific Association for the Study of the Liver, and the European Association for Study of the Liver, the ESA. We have many endorsers from different organizations, both patient organizations, NGOs, as well as scientific organizations. So the Society of the Liver Disease in Africa intends to transform liver health in Africa through collaboration, education, scientific exchange, and consensus, in addition, of course, to publishing newsletters every month and advancing clinical trials in the African continent. SOLDA's main objectives are to advance and disseminate science and practice of hepatology through many educational activities and conferences, the COLDA conference and partnerships. We foster research and facilitate consensus and practical guidance. And we plan to create a community of hepatology scientists and clinicians throughout Africa, promoting communication between healthcare professionals throughout the region. So this is the executive board. I'm currently the president. The vice president is Professor Wendy Spearman from University of Cape Town, South Africa. And we have a very unique board from different parts of Africa. All are experts in their fields and are great advocates for liver health in Africa. Currently, we have over 1,500 members from 37 African countries. As you can see, the distribution is almost unanimous. Eastern Africa, 36%, Western Africa, 28%, Northern Africa, 16%, Southern Africa, 16%, and 5% from Central Africa. The membership's benefits include sharing your work and receiving feedback from key opinion leaders, growing your professional network, contributing to advancements in the field, joining special interest groups and receiving a discount on COLDA registration and other educational activities on liver disease, organized by the Virology Education, and to vote on nominated board members, in addition to many webinars and newsletters and participation in some research. We have an annual conference, which is the COLDA. This year it's going to be in Cairo between the 19th and 21st of September. Skill building pre-conference sessions and workshops. The Lancet Journal actually is a collaborator, and they give regular webinars on abstract writing, as well as how to publish in Q1 journals, quarterly educational webinars, and regular updates on liver disease in Africa through our many newsletters. So please, we would like to encourage you and encourage you also to send this QR code to your colleagues to become members of SOLDA. We need scientists, clinicians, community representatives who are interested in the field of liver disease in Africa and who eventually will advocate and advance liver health in Africa. Enjoy your webinar.
Hello, everybody. Good morning, good afternoon. My name is Dr. Fumi Leshi from the WHO Global Hepatitis Program based in Geneva, Switzerland. I join Wendy and Manal in welcoming all participants and the global community to the SOLDA commemoration of World Hepatitis Day 2024. So globally, viral hepatitis A, B, C, D, and E are responsible for significant morbidity and mortality. Even as we speak, several countries in the region have outbreaks of hepatitis A and E, and effective national responses must include provision of clean water and sanitation. Now, the huge burden of chronic hepatitis B and C infections, however, are responsible for the most significant mortality from liver cirrhosis and liver cancer. The high incidence of new chronic infections, despite effective hepatitis B vaccination and other prevention tools, and a rising mortality rate that surpasses HIV and rivals tuberculosis deaths have been reported in the 2024 WHO Progress Report on viral hepatitis. So elimination of hepatitis B and C and D, they're feasible as we have the strategies and the tools for prevention, testing, and treatment. Now, vaccines, rapid diagnostic tests, and generic medicines are available at affordable prices, and local production is making it possible to reach even more people. One of the most important challenges we face is the implementation of all of these interventions at a population scale, and mobilization of domestic and catalytic fundings, as well as political commitment, alongside data, surveillance, community engagement, and partnership are needed to conduct or carry out major implementation activities, including hepatitis B burst dose, strengthening the childhood vaccination series, scaling up testing and treatment for hepatitis B and C, as well as ensuring WASH, that is water, sanitation, and hygiene for hepatitis A and E, in addition to ongoing hepatitis E vaccination. We look forward to an exciting webinar, and I thank all the speakers and participants and audience for participating in this webinar. Thank you very much, and over to you, Wendy and Mana.
Hi, everyone. Thank you so much for taking our time to join this webinar organized by the Society on Liver Disease in Africa. My name is Danjuma Ada. I am the past president at the World Hepatitis Alliance. I'm also the founder of CFID and CCT, both are charity patient-based organizations in Nigeria. I also chair the African Viral Hepatitis Action Group. So on this webinar, I am privileged to share about the patient's perspective on hepatitis B on this particular good day. So what actually is a patient perspective on hepatitis? These are some of the things we're going to look at. So there are very key messages I want to talk about. Number one, as we've heard in other presentations, viral hepatitis is one of the most communicable diseases for which mortality is on the increase. It's very unfortunate that despite the solutions, despite the effective treatment, hepatitis B and C still kills 1.3 million people as at 2022, similar to deaths from tuberculosis. And the global coverage of hepatitis prevention, diagnosis, and treatment is too low. In fact, far below the target. The target is to test 90% of people with hepatitis B and treat 80%, so as to reduce incidence and so as to reduce mortality. But this is really sad to know that we're far behind the target. We know that countries have developed plans and adopted the WHO guidelines. However, testing, uptake, and availability of diagnostics is still limited so far. Access to viral hepatitis treatment has not shifted to public health approach. This is some of the perspective for the patient community. Across most countries in Africa, hepatitis B care is still in specialized settings, urban, centralized laboratory hospitals, where majority of patients do not even have access to. So, unfortunately, treatment has not adopted a public health approach. Countries have adopted the WHO guidelines, but implementation lags behind, and the availability and affordability of treatment regimen is still limited. Despite the globally negotiated prices for hepatitis B and C, majority of countries don't have access to this. There are tools and data that can prevent diagnosis and treat viral hepatitis. But so what we lack is the time, the action to test more people and to treat more people. So it is time to act now. It is time to act in testing more people and treating more people. And in Africa, my continent, Africa, has 63% of new infections for hepatitis B. And unfortunately, the birth dose for hepatitis B vaccine is 18%. As a matter of fact, if you look at the data of the real timely birth dose vaccine within 24 hours of birth, it might be far less than that. And hepatitis C incidence is also on the increase across the region of Africa. In Africa, 771,000 infections occur, and these are really, really mind-blowing situations. Hepatitis B C kills 272,000 people. These are human beings. They're not goats. They're not animals. There is a father, a brother, a friend, an uncle, a mother, a child to someone. Now, what is the ground situation regarding viral hepatitis in Africa? Hepatitis B in particular is underdiagnosed in Africa, with only 4.2% diagnosed based on WHO data. However, real-world evidence suggests that lower percentage of people have been diagnosed, probably even maybe around less than 3% or even 2% have been diagnosed so far. There are no mass testing of populations like for example, the beautiful example of the mass testing in Uganda. The WHO data was probably pulled from hospital-based testings. So it's really difficult to say that that is a real reflection of, yes, it's a beautiful report that pulled data from 187 countries. But so hepatitis B is underdiagnosed across the region. There's no mass community-based testing and linkage to care for hepatitis B within the region of Africa. Now, what is the impact of hepatitis care on patients? Number one, there is the economic impact. Hepatitis patients face challenges in accessing quality care and are impacted by the health care costs. For example, there is a direct cost of expenses related to diagnosis, to antiviral therapy, and then to the lifelong treatment. We know that hepatitis B is lifelong treatment. So there is an impact on patients on the direct cost of diagnosis. Viral load costs in some places over $50, over $100 in some communities. And unfortunately, the diagnoses have not been simplified or decentralized. Majority of the diagnoses are based in urban communities, and majority of our patients do not have access or cannot travel long distances to the urban centers where they can access care. And chronic hepatitis B therapy is lifelong. So this impacts economically on the patients. And remember, majority of the patients are not on health insurance, so they have to pay out of pocket to access care. And that is why many patients are dropping out of treatment. They would rather go for quacks or they go for self-help. And this further drives the increased rate of people developing liver cirrhosis or liver cancer. So for hepatitis B, there's a challenge of monitoring. Chronic hepatitis B patients are required to frequently visit hospitals for management and care. How many patients can afford to visit hospitals regularly? They need to travel long distances. I'll give an example. In my state where I live in Taraba, there are certain places where you travel more than 10 hours by vehicle to go to the urban central hospital. How many patients can afford that? There's patients who spend a lot of money in traveling, who spend a lot of money in accommodation, who spend a lot of money in accessing care. And then what of hospitalization? Treatment of complications such as cirrhosis or liver cancer costs so much for the patients. So these are some of the challenges of the economic impact on the patient in hepatitis B care. There is also the indirect cost. There's a loss of productivity due to illness. Majority of these patients are subsistence farmers, people that survive on farming. And because they come down with ailment and sickness, they cannot afford to go to farm. They cannot afford to go to offices. Some people lose their jobs and they lose their source of earning and source of livelihood. The market woman cannot go to the vegetable market where she sells and get money to take care of the family. So loss of productivity due to illness is a major impact on the lives of patients. And we have the long-term disability and premature death contributing to economic burden in the society. We have orphans that are coming out of the society because they've lost parents. They've lost the breadwinner in the home who died because of liver cirrhosis. I have a case of wisdom, one of the very passionate, one of the patients we have in our facility, who had a 3-year-old daughter but passed on due to liver cancer from hepatitis B. So these are some of the challenges. We have the social impact, like stigma and discrimination. This is still a prevailing situation across African communities. So individuals with hepatitis B still face stigma and discrimination. And this impacts their mental health, employment opportunities, and social interactions. People are sacked from offices and jobs. People cannot migrate due to economic opportunities because of hepatitis B status or even hepatitis. There's low awareness. So public health initiatives are required to increase awareness and reduce stigma associated with hepatitis B. So in addition to the economic impact on patients, there are the health system challenges. Healthcare disparities exist. There are major disparities to access hepatitis B care and treatment, especially in our low resource settings in Africa, in rural communities, among marginalized populations, like sex workers, like migrant populations, like people who inject drugs, like adolescent boys and girls, young people in secondary schools, for populations that missed out the birth dose vaccines. We need to identify them. So the healthcare system challenges are challenges that we need to address. Stigma in healthcare settings is still an existing problem, and lack of strong infrastructural development in healthcare settings. So ensuring continuous and comprehensive care for individuals with hepatitis B, including regular monitoring and follow-up, can be challenging to the patient community. So it is time for us to act collectively towards ending or eliminating hepatitis in our motherland Africa. A patient that is not diagnosed today, who probably is having hepatitis B, may come down with liver cirrhosis or liver cancer in the next few years. Babies that are not vaccinated and protected with the timely birth dose vaccines might end up getting infected through vertical mother-to-child transmission. So we need to act now. Adolescents that miss out in birth dose vaccine, we need to test them. We need to screen more. We need to increase access to testing. Low-cost testing and treatment and diagnosis is what we need in order to move the needle towards hepatitis elimination in Africa. Africa needs to rise. Africa is lagging behind the data. 63% burden of hepatitis B in the region is not a good data. And I dare say, if we're not careful, Africa may lose the opportunity of having the young populations in the world, because we have the youngest population of people. Who knows if some of these young population are already having hepatitis and undiagnosed. So let us scale testing among adolescents, among children, among key populations, so that we will eliminate hepatitis in Africa and reduce liver cancer in the near future within this region of Africa. Thank you so much for listening, and I hope we act now. It is time to eliminate hepatitis in Africa and all over the world. Thank you.
Good afternoon, everybody, and thank you for this opportunity for me to share with you some thoughts on hepatitis A virus in Africa, a virus in transition. So by way of reminder, it is an uncoated RNA virus. It's a picornavirus. It's very resistant to an acidic pH, which is the reason it can make its way through the gastric environment, but of course inactivated by high temperature and chlorine, which is the reasons we encourage boiling of water, cooking of food, and the sanitizing of water. It, of course, is fecal-orally transmitted. From a clinical perspective, short incubation period, the onset of jaundice as the heralding sign of infection is really far more frequent with older people than younger people. And in terms of complications, an unusual cause of acute liver failure, but well-defined. And of course, complications, more likely in older people, can include this cholestatic variant, where people can remain jaundiced for weeks or months, or this relapsing remitting courses where enzymes rise and fall over a long period of time. And then, of course, the well-described phenomenon of hepatitis A unmasking or inducing autoimmune hepatitis. We look at the right block. The virus itself consists of both structural, non-structural proteins. The viral capsid protein VP1 sequence determines the genotype. There are about 6 genotypes globally. Africa, particularly sub-Saharan Africa, is dominated by genotype 1b. Diagnosis, well known as well. It's made by a positive hepatitis A IgM. Lasting immunity is the development of the IgG. And of course, viral shedding in the feces starts well before the onset of seropositivity for the IgM or the rise in ALT. It is a vaccine-preventable illness, but in general, WHO does not recommend routine vaccination in areas or countries where there's high endemicity. And in fact, no African country has included Hep A vaccine into their EPIs. However, WHO does recommend in-country epidemiological surveillance and determination based on evidence as to whether this is necessary. And this is the foundation of the point I wish to make, because the evidence is mounting. At the age of 10, seropositivity was starting to dip below 90%. When you fall below 90%, you're regarded as moving away from the high endemicity threshold. Already in West Africa in 2014, in this good review, looking at a whole lot of data from various countries, and it's a busy slide, and I'd recommend you get the paper, you can see already mounting evidence that in a variety of countries in West Africa, in fact, that we were moving away from the high endemicity threshold of 90% seroprevalence. And here the preliminary evidence clearly suggested that. We look at the study from about 1,200 plus children between the ages of 1 and 15 from an HIV clinic in urban South Africa. You can see at the age of 10, that threshold seroprevalence was actually below 70%, suggesting strongly again that in fact we're moving away from that high endemicity threshold. This again, data from last year, all the acute cases in South Africa, the block on the left showing the distribution for the various provinces, the block on the right showing the age distribution. And again, we seem to be falling down in terms of overall numbers of acute cases in that young cohort, which again, I'm saying is the threshold for what is regarded as high endemicity. So in terms of the best data we have on overall epidemiology, we've got this paper published several years ago, the left block showing all the studies in the various countries where the systematic review was drawn from. On the right top block, you can see overall seroprevalence in children and adolescents now falling down at about 57%, adults rising understandably to 95%. And across all age groups, bottom right block, you can see that we are clearly falling below this 90% endemicity. So a few final thoughts. Africa is clearly transitioning away from high endemicity to intermediate Hep A endemicity. Countries should start considering vaccinations into their EPIs. The question is, what is it going to cost? This is data just published from a modeling study looking at South Africa, published in May. And basically, implementation of a single dose of Hep A vaccine in this model below the age of 2 is cost effective when you look at a baseline approach. That approach has to include access to liver transplantation, interestingly, to make it cost effective in terms of reaching the cost efficiency threshold. So unfortunately, it still seems to be an expensive intervention, and we need more data. The take-home message, countries need to consider their local epidemiological data, build the database, and we need to move towards the evidentiary-based approach for introducing Hep A vaccine into our EPIs. Thank you very much.
Good morning, everyone. I'm going to be discussing hepatitis E in sub-Saharan Africa, an emerging disease. So it's estimated that 20 million hepatitis E infections occur worldwide, leading to an estimated 3.4 million symptomatic cases annually. The highest hepatitis E IgG seropositivity rate is in Africa at 22%, followed by Asia at 16%. It was first identified in 1983 during an outbreak of non-A, non-B hepatitis in Afghanistan. It is a small, positive sense, single-strand RNA virus. There are 8 genotypes and only 1 serotype. And humans are affected by genotype 1 to 4 and 7 and 8. In terms of transmission, this can be fecal oral, zoonotic, parental, and this includes blood donations and in utero transmission. Different genotypes are associated with specific transmission routes, with epidemic outbreaks associated with genotype 1 and 2, and zoonotic transmission with genotype 3 and 4 from pigs, and genotype 7 and 8 from camels. Sub-Saharan Africa accounts for 15% of all infections, clinical cases, and deaths from hepatitis E, and 25 countries have actually reported the presentations of hepatitis E infections. 50% of reported outbreaks occur amongst refugees and internally displaced persons within camps in Chad, Nigeria, Central African Republic, Ethiopia, Kenya, Uganda, Namibia, Sudan, and Somalia, with the largest documented outbreaks being in East Africa from Uganda and Sudan. Also accounts disproportionately a high number of stillbirths at 29%, and the average age of infection is 15.5 years compared to the global average of 17.7 years. So we look at the epidemiology and the IgG seroprevalence rates in sub-Saharan Africa. We note that in pigs it's up to 64%, pig handlers 30%, and this raises concern that zoonotic transmission is an important route of transmission. But pregnant women, 19%, blood donors, 18%, HIV-infected individuals, 21%, and even children have a seroprevalence of up to 15%. North Africa accounts for 14% of all global infections, but only 8% of symptomatic cases and deaths, and they have a very low average age of infection at 8.1 years. So in terms of clinical presentation, it tends to be asymptomatic in most individuals. The symptomatic infections tend to be self-limiting, often mistaken for other causes such as hepatitis A, yellow fever, and drug-induced liver injuries, and they present with fever, nausea, vomiting, and jaundice, the attack rate being highest in men aged 15 to 40 years, and symptomatic infections occur in about 15% of outbreaks. Severe disease is seen in pregnant women and individuals with pre-existing chronic liver disease, and acute liver failure in pregnancy accounts for 20 to 70% mortality during that second and third trimester. Of concern, in Senegal, during an outbreak, there was 100% mortality amongst pregnant women during the outbreak of 2012 to 2014. Chronic hepatitis is associated with genotype 3 and 4 infections, and this involves solid organ transplants, HIV-infected individuals, and hematological malignancies. And here the risk of progression to chronicity is 60%. Transaminitis tends to be mild, jaundice is uncommon, but there can be rapid progression to cirrhosis. Importantly, one needs to remember the potential existence of extrahepatic manifestations involving neurological, renal, and hematological symptoms. So patients presenting with acute hepatitis and unusual systemic symptoms, one needs to actually remember that hepatitis E might be the cause. In terms of laboratory diagnosis, the incubation period for hepatitis E is 15 to 60 days, with an average of 40 days compared to 28 days for hepatitis A. And the RNA is detected about 3 weeks post-infection in blood and stool and shortly before the onset of symptoms. In terms of diagnosis, at the clinical onset, biochemical markers become elevated, and we can either make the diagnosis serologically, looking at the IgM or the IgG. But importantly, to confirm active infection, one needs to actually measure a detectable hepatitis E RNA. Immunosuppressed patients with chronic hepatitis E, unfortunately, the E antibodies are often undetectable. So if it raises the concern of hepatitis E, particularly chronic hepatitis E, you must check for the hepatitis E RNA. In terms of treatment, for acute infection, most cases will spontaneously clear, but this does not provide long-term immunity. In fact, patients who have been infected can subsequently be reinfected. Ribavirin can be considered for cases of severe acute hepatitis or acute on chronic liver failure. And reduction of immunosuppression is the first therapeutic step in solid organ transplants, and this can result in clearing of the virus in up to 30% in patients just on reducing immunosuppression. For chronic hepatitis E, one can consider 3 to 6 months of ribavirin monotherapy, and if there's persistent hepatitis E replication or relapse, pegylated interferon for 3 months can be considered, but only in liver transplant patients. But most importantly, one needs to look at prevention. Hepatitis E is less resistant than hepatitis A to environmental conditions such as temperature, and prolonged hepatitis E excretion in the stool following symptomatic or asymptomatic infections is rare. It's important that we understand the reservoirs of infection. Undiagnosed subclinical and clinical cases may be drivers of epidemics, and wastewater surveillance for detection of non-clinical cases in communities are very useful to actually detect and upscale in the risk of hepatitis E within communities. And this has been undertaken in terms of South Africa, Cameroon, Egypt, and Tunisia. But importantly, one needs to ensure safe sanitation and water, and zoonotic transmission can be decreased by cooking meat to more than 70 degrees. Unfortunately, there's no protective immunoglobulin, and the hepatitis E vaccine, the Herculin, which was first licensed in China in 2012 and subsequently in Pakistan, involves 0.1 and 6 months injections and has been approved for use in emergency settings by WHO since 2015. So we look at the use of the hepatitis E vaccine within sub-Saharan Africa. This has been done in South Sudan during epidemics. Mass vaccination campaigns were supported by the MSF together with the Ministry of Health, and this was first undertaken in 2022 in one of the internally displaced camps when outbreak had been ongoing for more than 2 years. They targeted the most vulnerable, pregnant women and women of childbearing age. They identified those who were infected with rapid tests and provided medical care. And importantly, they provided public health educational messages on prevention measures via the radio. And they aimed during that program to provide protection for over 25,000 people. More recently, in 2023, in Mafanga County, where it's been affected by recurrent flooding, isolating communities and resulting in a breakdown in sanitation and safe water, they implemented the vaccine program during the acute stages of an active hepatitis E outbreak. And by June of this year, they aim to have fully vaccinated 12,000 women and girls aged 16 to 45 years. So in summary, hepatitis E is endemic in sub-Saharan Africa. It's responsible for a significant proportion of acute cases and a high rate of poor outcomes, including mortality in pregnant women and individuals with chronic liver disease. The true burden of active infection is difficult to estimate. Most studies have focused on serology rather than the RNA. Contributing factors include conflict zones, displacement of people and urbanization of slums, resulting in a breakdown of sanitation, contaminated water supplies, and overcrowding. And the increasing demand for pork across the continent raises the potential of increasing zoonotic transmission. So we really need to have access to effective vaccines, particularly amongst high-risk groups, pregnant women, and refugees and IDPs during outbreaks. So I hope I've shown you that hepatitis E is something that we need to think about within sub-Saharan Africa, and we really need to motivate for increased access to the protective vaccine. Thank you very much.
Ladies and gentlemen, viral hepatitis B and viral hepatitis D, two heavy burdens on sub-Saharan Africa. Our outlines. Introduction and context. First, the burden of hepatitis B. Sub-Saharan Africa is a very high prevalence area of hepatitis B, between 8 and 18%. So we have 64.7 million people living with hepatitis B, with a very poor cascade of care, as you see here, because we have so many people infected, but only 4.2% are diagnosed and only 0.2% are treated. Hepatitis B prevalence. A very high prevalence for most of our countries in Africa. More than 4.7 million children are under 5 years live with chronic hepatitis B, putting them at risk of liver cirrhosis and cancer. Furthermore, when contamination of neonates, the risk of contamination or chronicity is up to 90%. Effectively, the evolution risk of chronic hepatitis B infection is liver cirrhosis and cancer. We see here that in Cameroon, 65% of our HCC are due to hepatitis B virus. Now, the burden of hepatitis D. Hepatitis D virus requires hepatitis B virus for its replication. So you can have co-infection, that means HBV plus HDV simultaneously, or you can have super infection, that means you first have hepatitis B, then later you have hepatitis D. The combination is the most severe form of chronic hepatitis. So every people living with hepatitis B should be tested for HDV. The new guidelines recommend reflex testing to all chronic hepatitis B patients. This is the geographic distribution of hepatitis D virus. You see that many of our countries are in medium-sized prevalence. In people living with hepatitis B, 5% of them have hepatitis D. There is some geographical hotspots of high prevalence of hepatitis D infection, including some countries in Western and Central Africa. you see here that, for example, in Cameroon, we have some spots, some areas with very, very high prevalence, more than 50%, as you see here. Testing strategy for hepatitis D diagnosis. When we use the total antibodies to screen, when this total antibody is positive, we go for HDV ARNA testing, and then we have the diagnostic. A reminder of WHO HBV targets. That means that for 2030, we need a children prevalence of less than 0.1%, with also important reduction of new infection and important reduction of death. So there is a need for action. Concerning prevention, first, education and sensitization. We should sensitize and raise awareness in general population and health authorities, engage empowered communities and civil society, involve midwives, nurses, gynecologists, pediatricians, explain transmission modes, need for more health facilities, and drive decision for action. Eliminate stigma, discrimination, and all barriers. Second is the screening and linkage to care. WHO mainly recommends screening of high-risk group as usual, as you see here. But we think that we should extend this screening to the general population. Third is the prevention of mother-to-child transmission of HBV. The mother-to-child transmission of HBV is a major mode. Most of the global burden of chronic hepatitis B is due to vertical transmission at birth. Mother-to-child transmission of HBV is responsible for 2/3 of HBV-related liver disease in Africa. This transmission in Africa is 10%, but if nothing is done, by 2030, we should have 50% of new infection coming from mother-to-child transmission. The algorithm for antiviral prophylaxis in hepatitis B pregnant women. This is to say that if this HBV DNA testing is more than 200,000 international units per ml, we should start tenofovir prophylaxis since the second trimester. And also another important point is to say that when no testing is available, we can offer tenofovir prophylaxis to all positive surface antigen positive pregnant women. Assessment for eligibility for long-term treatment is to be seen in the next slide. Don't forget the timely hepatitis B boosters vaccination of neonates within 24 first hours, followed by EPI. Fourth is hepatitis B vaccination. This vaccination is available for all age groups, as usual, and you see here the vaccination schedule. Of course, this vaccination also protects against hepatitis D. A few words on the new 2024 WHO guidelines. These guidelines include expanded and simplified treatment criteria, expanded eligibility for antiviral prophylaxis for HBV-positive pregnant women in mother-to-child transmission prevention, improving HBV diagnostics through point-of-care HBV viral load, and perhaps this core-related antigen of hepatitis B virus. Who to treat among people living with chronic hepatitis B? You see here that first, any people with significant fibrosis, more than F2, as you see here. Also, HBV, regardless of the HBV DNA and ALT levels. Second, HBV DNA, more than 2,000 international units per ml, and ALT levels more than the upper limit of normal. Third, in case of presence of any of all the following, that means co-infection, family history of liver cancer or cirrhosis, immune suppression, comorbidities, extrahepatic manifestations. And fourth, persistently abnormal ALT levels alone in case of absence of HBV DNA assay. Here are the antiviral drugs we can use. In the other cases, on the right side here, these cases we don't need treatment, we only need to follow them and to screen and to monitor. In case of cirrhosis or family history or liver cancer and cirrhosis, we must monitor the patients every 6 months with alpha-fetoprotein and ultrasound. In case, we must also follow the disease progression every 12 months. These are the preferred alternative treatment and first-line treatment for hepatitis B. Hepatitis D treatment is pegylated interferon alpha and or with buliveritide, which is a new drug. This is to summarize the steps of HBV guideline recommendation on treatment. You see here staging with non-invasive test, who to treat here, first line treatment, treatment failure, what to do in this case, treatment discontinuation, the stopping rules, monitor treatment, monitor the result of the treatment and the toxicity, also monitoring of HCC, and finally, the prevention of mother-to-child transmission with antiviral prophylaxis. The new recommendations in 2024 reduce the APRI score to more than 0.5, and also the recommendation for 2024 is that we start the antiviral prophylaxis from the second trimester. The key topics of new hepatitis B guideline across the cascade of prevention, diagnostic and treatment and care. First here is simplified testing and diagnosis, simplified treatment criteria, simplified services delivery models. And also here, serologic testing, HBV DNA, linkage to care, treatment and monitoring. There are many new HBV drugs in the pipeline and potential for combination therapy in order to try to cure this hepatitis B. Primary care providers must take an expanded role in HBV management and be more engaged. They are the first-line providers to diagnose and manage hepatitis B, but there is many barriers as complexity of guidelines, lack of confidence and knowledge, determining treatment eligibility requires multiple tests, as you see here. There are so many. So there is a need to training for this primary care provider. In conclusion, we hope a significant reduction in the prevalence of HBV and HDV infection. Mother-to-child transmission needs to be improved as a priority, large-scale screening and linkage to care, and also expanded and simplified treatment criteria. But hepatitis B burst dose implementation remains a challenge. The biggest challenge is the systematic free hepatitis B vaccine for all newborns in Africa, because you know that we still have a lot of no prenatal visit and many home deliveries. We must decentralize viral hepatitis services to rural area and primary care providers. For the implementation priority, we must first scale up and testing and care findings. Second, updating national guidelines with local context. Third, we spread education and awareness raising campaign among communities and healthcare workers. Fourth, promote wide access to training and capacity building of healthcare workers. 5, cost reduction for HBV meds and diagnostic. Thank you for your attention.
Good afternoon. Today is a very important day, Hepatitis World Day, an important day for all of us, and a very special day, of course, in Egypt. It's really a story of success. When you back to the magnitude of the problems, approximately more than 70 million people are living with hepatitis C worldwide, with the highest incidence in the Eastern Mediterranean and European region. This is according to WHO 2019. And until 2016, Egypt is having had the highest prevalence worldwide by the last prevalence at that time in 2015 by 7%, almost closer than 6 million with viremic hepatitis C positive. Also, worldwide, there are a lot of European countries had a high incidence, relatively high incidence of hepatitis C virus. According to the African region, WHO African region, hepatitis C virus, 21% of the people living with hepatitis C knew their hepatitis C status, and 62% people diagnosed with hepatitis C infection had been treated using the DAAs between 2015 and 2019. So hepatitis can't wait. A modeling study has shown that 1 year delay in the hepatitis diagnosis and treatment could result in an additional more than 44,000 liver cancer and more than 70,000 deaths from hepatitis C globally by 2030. So elimination program is crucial, and according to the WHO Day, there is the theme of elimination of hepatitis C as early as possible. So what are the challenges in Africa to eliminate and to implement a program for elimination of hepatitis C virus? It should be put in view of the WHO call 2030, rising awareness, health education program, legalizing infection control measures, supervision of blood banks and dialysis machines, in addition to improving injection safety to reduce the iatrogenic transmission, screening program by increasing testing for population at high risk, and systemic population-based seroprevention, seroprevalence, and treatment as a prevention for all patients with positive cases, providing the possible successful treatment for every patient having positive testing. And also, to facilitate the elimination of virus C in the continent, there should be a comprehensive strategy by task shifting to nurses and non-specialists, decentralization to primary care facilities, micro-elimination approach tailoring towards hard-to-reach population, and minimal monitoring approach to minimizing face-to-face appointments. What about countries on track? Of course, Egypt and Rwanda are both countries are on track. Egypt, through its nationwide screening and treatment campaign, 100 million healthy lives in 2018 and 19, screened nearly more than 60 million individuals for anti-hepatitis C antibodies, and were able to treat more than 4 million people living with Hep C virus. This led to the WHO awarded Egypt the gold tier status on the path to hepatitis C elimination on October 2023. Rwanda as well is on track to eliminate hepatitis C by 2040, with 7 million people having been tested for hepatitis C and more than 60,000 treated, thereby reducing the prevalence of hepatitis C infection to less than 1%. In addition, hepatitis B as well, 5 million people have been tested for the hepatitis B. 7,000 are on lifelong nucleoside treatment, and 7 million people vaccinated against hepatitis B. What about the Egyptian program, the successful Egyptian program? When you see this graph on the left side, you have the distribution of the high prevalence of hepatitis C in Egypt, and the green color it was in the Nile Delta, low part of the Egypt. The Nile Delta is having the highest prevalence of hepatitis C. And when you get into the upper Egypt, you are going to have a less prevalence. So the Nile Delta and Cairo was having the highest prevalence of hepatitis C in the country. And this, the second graph, is the distribution and number of hepatitis C patients registered monthly for the treatment. And by 2017, starting the national screening campaign. And here's the story. Started 2006 by launching the Committee for the Control of Hepatitis C virus in Egypt, introducing the pegylated interferon, and SVR was not exceeding 40%. Then 2014, the introduction of the DAS for the first time, the brands, and the negotiation of the international companies to reduce the price. Then 2016, the introduction of the generic and the industrial localization to produce the molecules in Egypt, which has it was a breakthrough to provide the treatment for every patient with positive Hep C virus in Egypt. Then 2017, starting for the first screening program, and the very successful screening program was started in 2018 by the 8 million healthier lives nationwide, the famous one. And accordingly, we have at that time more than 172 treatment centers and more than 120 clinics dispensing the treatment. The treatment program started in 2006, 26 specialized treatment centers, anticipated with the interferon therapy, and then started from 2014 and 2018, plan for action for prevention and treatment, advocacy, educational communication awareness, blood safety, safe injection, surveillance, vaccination, and the treatment more than 300 annually per year. And here's the distribution of the treatment along with the time and along the years. And by 2017, the patients treated were those living with the diagnosis, 2 to 3 million with undiagnosed Hep C virus infection untreated, and more than 60,000 identified through the screening campaign with a mobile team, visited villages and nearby hoods areas. And the successful screening program after treatment every patient with Hep C virus positive was in different stages. First, in 2018, beginning 2 months, planning, preparation, recruitment, training. Then the real campaign, screening campaign, went in 3 phases. Phase 1, October to November 2018, it was 2 months. 9 states, target population more than 17 million, and more than 5,000 medical team. Phase 2, 11 states, target population more than 20 million, with more than 6,000 medical team. This was in December to February 2019, and from March to April 30, 2019, phase 3, with 7 states, target population more than 23 million, with more than 8 medical team. And finally, at the end, the data analysis and the evaluation. And according to this campaign, we had the prevalence according to the age group was on the maximum with the age of more than 18 years by 4.5%, 0.4% from 15 to 17, 0.2% from age 12 to 14, 0.7% refugees, and 14% special group. And the successful elimination was 3, according to the timeline of 3 streams: the problem stream, adjusting the problem and definition of the problem, policy stream, and political stream and political backup, which was crucial at that time. The three streams going together and at the end collaborating at the end to have the successful program. So the effective planning advocacy was plan for implementation, action plan, collection and analysis of the necessary information and data acquisition, obtain governmental commitment, which was very important, empower the public for strong leadership, engage all stakeholders, and build up in accountability and monitoring framework, surveillance, and leverage on previous experience and integrate in existing infrastructure when possible. It's worth to mention that after the successful treatment of hepatitis B in Egypt, we are expecting to have a decreasing incidence of hepatocellular carcinoma by the year 2030 by more than 100,000 cases will be prevented for evolution of hepatocellular carcinoma. So this was the story and the successful and happy ending by having the gold tire, which has been acknowledged from the WHO to Egypt as the first country to get elimination of the hepatitis C virus. So at the end, the viral hepatitis remains a major public health problem threat in Africa. Elimination is feasible by adoption and implementation of the tools which can prevent liver cancer and save lives if we can act now. Evolving responses and lessons learned provide opportunities and guidance to scale up towards the 2030 elimination target and alignment of health system and services in evolution and collaboration. Thank you very much.
Thank you, Professor Omar, for really giving us insights of what is actually achievable if you have political will to implement an elimination strategy, but also close involvement of the community. So we're going to move on now to Western Africa. Professor Fumi Lessi and Dr. Jibril Nadal. And Jibril will be giving the presentation on prevention of hepatitis B mother-to-child transmission in Africa.
Good morning, and thank you for inviting me to this important World Hepatitis Day webinar led by SOLDA. I am Jibril Ndao. I am a clinical research fellow based at the MRC unit in the Gambia. And today I will talk to you about prevention of hepatitis B mother-to-child transmission in Africa. It's clear to us all that mother-to-child transmission remains a very important route of new hepatitis B infections. And because hepatitis B infection acquired at or near the time of birth increases the risk of chronicity, mother-to-child transmission is a major contributor to the chronic hepatitis B cases globally. We have effective tools to prevent mother-to-child transmission. There's been a vaccine that has been available for decades now. We have effective antivirals that can be used as prophylaxis. However, the scale-up and implementation of these tools have been uneven globally. Whereas in Asia, the adoption and implementation and scale-up of vaccination, prophylaxis in pregnancy, and antibodies in newborns have largely resulted in a significant reduction of new hepatitis B mother-to-child transmission cases. In Africa, it is not so. Therefore, it is estimated that by 2030, about half of all new hepatitis B infections will be by mother-to-child transmission. Our program in the Gambia has further shown that infections acquired through mother-to-child transmission are associated with an increased risk of liver cancer in adulthood. As a result, mother-to-child transmission not only contributes towards the continued new cases recorded globally for hepatitis B infection, but also impacts the mortality and morbidity associated with hepatitis B globally. As a result, it is not possible to achieve the elimination targets for hepatitis B without eliminating mother-to-child transmission. Because we have tools to prevent mother-to-child transmission, the WHO has, in a series of guidelines, produced guidance for hepatitis B screening, for prophylaxis, and for vaccination. And in 2020, the first guidelines dedicated for hepatitis B mother-to-child transmission were launched. And these recommended routine testing for all pregnant women for hepatitis B surface antigen, followed by hepatitis B DNA viral load or antigen testing to identify women who need prophylaxis. And in those who are eligible for prophylaxis, to be started on daily tenofovir, ideally at around 28 weeks of pregnancy until after delivery. These guidelines were expanded and further simplified this year in the March 2024 WHO hepatitis B guidelines, where the recommendations for hepatitis B surface antigen testing in all pregnant women is retained. Where available, hepatitis B DNA viral load quantification or antigen testing can be done to identify women in need of prophylaxis. But in settings where DNA or antigen testing is not available, women can be started on prophylaxis based on hepatitis B surface antigen positivity. And this prophylaxis is in addition to the significantly expanded WHO criteria for antiviral therapy amongst pregnant women and adolescent girls, which covers about half of the hepatitis B infected population. So with these expanded and simplified guidelines in place, let's quickly have a look at where we are as a continent in terms of hepatitis B mother-child transmission. Estimates in 2022 in the Global Hepatitis Report estimates that about 2/3 of all new hepatitis B infections are recorded on the continent. An earlier systematic review and meta-analysis done by Yusuke and Keane estimated that about 350,000 new hepatitis B infections in Africa acquired through mother-child transmission. As a result, the prevalence of hepatitis B surface antigen amongst the under 5 population is 2.3%. More recently, Alex Stockdale led a systematic review and meta-analysis of 120 studies done in more than 29 countries across sub-Saharan Africa, which included more than 190,000 women. And the study aimed to estimate the prevalence of hepatitis B surface antigen amongst these pregnant women and the rates of mother-child transmission. Prevalence of surface antigen has declined from about 7% in 1990 down to about 4% in 2022. And the decline was recorded in all the regions of Africa, more significant in Central Africa, where the starting prevalence was much higher compared to West and East Africa. In terms of hepatitis B mother-child transmission events, 11 studies from 9 countries, including 1,280 mother-infant pairs, were included in the meta-analysis and systematic review. The rates of mother-child transmission were estimated in these studies, stratified by whether the mother received maternal antiviral prophylaxis during pregnancy and the timing and completion of the hepatitis B birth dose and hepatitis B vaccine series in infancy. Overall, in studies where the women did not receive any maternal prophylaxis during pregnancy, the estimated hepatitis B mother-to-child transmission events were 3.9% for those who received a timed hepatitis B birth dose vaccine, 5.9% for those who received a delayed birth dose vaccine, 7.3% in infants who did not receive a hepatitis B birth dose but completed the hepatitis B vaccine series, that's the 3 hepatitis B infant vaccinations, and 15.5% amongst unvaccinated infants. And in studies where maternal prophylaxis was provided during pregnancy, rates of mother-child transmission were significantly reduced. The Alex and team estimated that there were about 340,000 hepatitis B mother-child transmission events in Africa in 2011. And this reduced by more than half by 2022, estimated at about 172,000 hepatitis B mother-child transmission events. They further modeled that if we're able to scale up the hepatitis B vaccine series, the 3 hepatitis B vaccinations and hepatitis B birth dose vaccine coverage to the WHO recommended targets of 90%, hepatitis B mother-child transmission events would reduce by a further 97%. That's an additional 44% reduction. And should this be coupled with 90% coverage of hepatitis B antiviral prophylaxis amongst women with high viral load, we would attain a reduction of about 86%, which would bring us to the WHO elimination target. Now, why can't we achieve these targets? First, I'll start with the timely birth dose vaccine. In the Gambia, we used HDSS data, which is from the general population in the rural part of Gambia. And we looked at the trend of timely hepatitis B birth dose coverage from January 2015 to December 2021. Overall, we included about 71,000 live births during this period. And we observed that the coverage of timely hepatitis B birth dose vaccine increased from about 1% in 2015 up to about 22% by 2021. The coverage was slightly affected by COVID-19 with a dip of about 50% during the first wave of the COVID outbreak in the Gambia, but it recovered almost immediately, achieving targets even before the COVID period. Now, when we looked at the factors as we delayed hepatitis B birth dose vaccine coverage, the most important factors were being born over the weekend, being born on a Friday or Saturday, being born during the rainy season, and being born to an older mother compared to younger mothers. In terms of providing and meeting the targets for hepatitis B screening and antiviral prophylaxis during pregnancy, the evidence is clear that vaccination alone is not enough to eliminate hepatitis B mother-child transmission. We've seen that in the systematic review by Alex Stockdale, and we have also seen that in previously published results, both from the Gambia and from Cameroon, where it is estimated that even with timely hepatitis B birth dose vaccine coverage, there is a residual risk of hepatitis B mother-child transmission, especially amongst infants born to mothers with high viral load. Coverage of prophylaxis amongst highly viremic women in Africa the data is not available, but the Polaris group has estimated that globally, only about 3% of women with high viral load have access to maternal prophylaxis. In the Gambia, we screened 10,000 pregnant women to assess the acceptability of hepatitis B surface antigen screening during pregnancy and the prevalence of hepatitis B and high viral load amongst this population. Overall, antenatal surface antigen screening was well accepted, but coverage prior to our study, which is coverage of surface antigen screening in the routine antenatal care, was low, with only very few women having had a prior hepatitis B test offered to them. Out of 9,681 women that we tested in our study, we found a prevalence of 4.5%, of whom about 7% had high hepatitis B DNA viral load. Most of these women had never had a hepatitis B surface antigen test done before, even though the median pregnancy amongst them was more than 2. And at the time of the study, tenofovir prophylaxis was not accessible to any of these women in the Gambia. So to summarize, we do have the tools and we have the capacity to be able to integrate and scale up the tools we have to eliminate hepatitis B mother-child transmission in Africa. But in order to do this, we need an integrated and decentralized service delivery where hepatitis B surface antigen in pregnant women is integrated within the HIV and syphilis screening that is offered as part of the antenatal care package with adequate sensitization and education of the women. We need significant capacity building both for raising awareness amongst pregnant women, but also for training healthcare workers to be able to screen and monitor pregnant women and offer the services, including prophylaxis and birth dose vaccination for women who need these. We need to leverage on new opportunities, especially through the Global Fund support and investments to reduce new infections of hepatitis B infection, which includes amongst pregnant women and mother-child transmission, and the recently announced Gavi support for scaling up support for hepatitis B birth dose vaccine in high endemic countries. And finally, we need to think of adaptive strategies to increase coverage of timely hepatitis B birth dose vaccination, especially during critical time periods such as weekends, public holidays, and in evenings. And we must integrate hepatitis B birth dose vaccination within the essential early neonatal care package offered as part of the maternal and neonatal and child health management. I would close with an Amharic proverb which loosely translates that when the webs of the spider unite together, they can stop a lion. Therefore, when the different programs that are currently working in parallel to each other and all the stakeholders come together, we do have what it takes to eliminate hepatitis B mother-child transmission in Africa. Thank you.
Thanks very much, Jobo. Really highlighting that mother-to-child transmission really is driving infections in the future, and a simple vaccine can actually prevent this. But I think really also highlighting those practical challenges that we face, particularly in communities. And really, I think we need to be learning from champion countries like Vietnam, Indonesia, which actually looked at sort of auxiliary healthcare workers to actually deliver the vaccine at home. So I think really highlighting the importance of what we need to do to actually reach our communities. So our next presentation is from Eastern Africa, Dr. Mercy Nkowa and Professor Ponciano Okama. We're going to be looking at viral hepatitis amongst key and vulnerable population, and Professor Okama is going to be giving the presentation. Thank you.
So I'm going to give this presentation on viral hepatitis among key and vulnerable population. And this presentation, I'm giving it on my behalf and on behalf of Mercy Nkowa from Kenya. So I will have a brief background and talk about what the composition of the population is and why we are focusing on this. And then I give two brief case studies, one from Uganda on hepatitis B and another one from Kenya on hepatitis C, and then we conclude. So hepatitis B and C infections account for a significant global disease burden and high mortality from particularly liver cancer and cirrhosis. These infections occur in all WHO regions, with hepatitis C burden being high in the Eastern Mediterranean and European regions, and hepatitis B in Africa and Western Pacific. Hepatitis C burden is high in people who inject drugs, people in prisons, and men who have sex with men. And this is similar to what we see with hepatitis B as well. And that only means that screening and treating hepatitis C in this key population is needed if we are to reach the elimination goals for viral hepatitis by 2030. So who are these people we are talking about? These are generally groups that are categorized by behavior or gender identity, who are at high risk of contracting hepatitis and other blood-borne infections. And they include female sex workers, men who have sex with men, people who inject drugs, transgender people, people in prisons, fisher folks, truckers, and discordant couples. But then why do we then focus on this population? High-risk behaviors such as condomless sex and unsafe injecting, which are in general more common in key populations, are also among those that increase the risk of acquiring viral hepatitis and other blood-borne infections. These people face disproportionate levels of stigma, discrimination, violence, human rights violations, and criminalization. They also have significant barriers, and some of these are social barriers, legal, structural, and other contextual factors. For example, they face police harassment, societal discrimination, and insufficient community-based services, which actually prevent them from getting the care they need. They have inequitable access to safe, effective, and quality healthcare services. In fact, they do not even want to go to attend services in the places where the general population will usually go. They have increased vulnerability to infectious diseases, including these viral infections we are talking about, HIV and sexually transmitted infections, and they have obstructed access to health and other essential services. Approximately 13% of all new infections are actually attributed to this population, and this is generally increasing. Their HIV prevalence is high compared to the general population, and because HIV transmission is similar, continue fueling the epidemics of these viruses as well within the general population, making it difficult to actually eliminate viral hepatitis as is planned by WHO. At this point, I will give a brief snapshot of some of the case studies, and I'm going to start with Uganda. And here we are talking about the Uganda Prisons Serobehavioral Survey that was actually launched by government in 2013-2019. And the goal of this was to comprehensively assess HIV epidemiology and services for planning, developing, implementing, and evaluating HIV/AIDS prevention, care, and treatment services for the prisoners and also for the prison staff. In this survey, other infections were also tested for, including viral hepatitis B. The survey had a sample of close to 12,000 persons, of whom about 10,000 were prisoners, and the remaining was for the prison staff. The recruitment took place in 117 units, prison units in the country. Now, as you can see in this figure, the map of Uganda, the red dots form the areas where this the recruitment took place. And the most important part here is to show that hepatitis B virus prevalence was 7% among the inmates compared to the national average of 4.1%. So this is a high prevalence of hepatitis B compared to the general population. I then turn on to the Kenyan case study where there was hepatitis C testing and treatment among people who inject drugs. And this was done in some kind of a study with experience from test and linkage to care of those who have hepatitis C, those who inject drugs actually. This was also a government project, and the intention was to identify those people who inject drugs, offer them testing for hepatitis C and HIV, and for those who would test positive for anti-hepatitis C, they are offered PCR testing for hepatitis C, and those who are positive on PCR would be treated. The study looked at 2,188 participants, of whom 13% were found reactive on the BioLine rapid test, and 284 were analyzed on PCR, and 230 were found positive on PCR. And this is 81% of those who were actually analyzed on PCR. And for this particular report, this study, first of all, performed the feasibility of treating these persons. And so 95 of the people who inject drugs were actually enrolled for treatment. And among 92 of the 95 who initiated treatment, 85 completed the treatment. And when they were treated, the SVR rate was up to 92%, which was really quite good. And but then 3 were missing SVR labs, 3 had detectable virus. In other words, 3 of them failed treatment. The other persons who were tested in this study were then treated following this particular treatment algorithm to show the feasibility. So in conclusion, key and vulnerable population continue to drive the hepatitis epidemics and may actually thwart the elimination goal. Targeted programs is required for the population to enable progress towards elimination of viral hepatitis. And finally, hepatitis C treatment is feasible even in Africa. Thank you very much for listening to me.
Thank you very much, Ponciano, for really highlighting our vulnerable populations that we need to address and really have an approach of how we're actually going to reach them and identify them and get them care, often within their own communities. So we've had 5 presentations now from the different regions, and it gives me great pleasure now to invite Professor Lessie, who leads the global HIV, hepatitis and STI programs at WHO, to really give us insights into where we are in Africa and what we should be doing as as a group really to enhance the elimination goals. Fumi, over to you.
Thank you very much. And many thanks to Professor Manal and Spearman and SOLDA for this webinar to commemorate World Hepatitis Day. And I'm Fumi Leshi, like I said, from WHO. I just have to reflect on the excellent presentations and that highlight the importance of hepatitis A and E, both of which are fecal-oral, as well as hepatitis B, C, and D that cause liver cirrhosis and cancer. I think a lot has been said by all the speakers, and I do not want to really repeat what they have said. Now, WHO has globally recognized Egypt with the gold tier hepatitis C path to elimination, as well as Namibia, who received the silver tier for hepatitis B PMTCT. And there are others in the pipeline. So the importance of government action and investment is critical to moving the response forward. Now, the 2024 progress report reminds us that it is time for action. And we have heard from your 5 speakers different perspectives of the action that needs to take place, of course, including scaling up testing and treatment in all populations, including key populations. So I really want to highlight the role of partnerships, and I think I'll just take a minute to talk about partnerships and how partnerships are key to reaching elimination, the targets of which have been highlighted. Partnerships with communities of people who live with both hepatitis B and C, partnership with researchers and academicians and professionals, hepatologists, lab technologists, and the whole array of healthcare workers, as well as partnership with funders. And regarding funders, just want to highlight some of the key global funders, including Gavi, that is the Vaccine Alliance, that has released the application and proposal to support countries with hepatitis B birth dose. We have about 6 countries currently preparing applications for the first window, with the second window opening in September. That will really provide support for many West and Central African countries that have high levels of hepatitis B prevalence and low hepatitis B birth dose coverage. The second global funder is Global Fund, and we are so pleased that they have expanded their portfolio for hepatitis B PMTCT, and many countries are taking advantage of this and have included antenatal testing and screening of pregnant women for both HIV, hepatitis B, and syphilis in the triple elimination agenda. And this promises to support many countries as they integrate at least on this platform. And that becomes an entry level for many countries for the hepatitis B response. I will also mention UNITAID that opened the grant earlier this year for triple elimination, and we anxiously await the outcomes because this is another project that will provide catalytic support for the Africa region. The Hepatitis Fund is also a funder and has provided support to several countries, and we also hope to hear from them at least very soon by World Hepatitis Day. I mentioned also other partnerships that are outside of hepatitis. We have internal partners in communicable diseases, in non-communicable diseases, partners who work with universal health coverage. These are potential partners to really scale up hepatitis. And I would mention as well that as we work towards national insurance health programs, it's important that we advocate for inclusion of hepatitis B and C interventions within national health programs. So thank you. I'm going to hand over to you. There are huge opportunities which we need to take advantage on to reach elimination by 2030. So thank you very much, and over to you.
Thanks, Fumi. I think really ending on quite a positive note, really emphasizing the importance of collaborations across very different levels, but also actually highlighting the opportunities that we have. So I think that's a very positive end to our formal presentations. And we're now going to open it up to questions. And in the chat, we've got, I'll start off with the first one on hepatitis E from Patrick Amisi. Is it true that hepatitis E is classified as a dirty hands disease? So I think that raises quite an important issue, is the language that we use in terms of describing transmission, reaching communities, and not using sort of stigmatizing terminology. So I think we need to realize, we look at hepatitis A and E, it's a fecal oral transmission. So obviously you can get it from contaminated water, from poor sanitation. And so washing of hands is essential, but that applies really for general health. So I think we need to realize that we need to, and particularly where we have outbreaks, often the outbreaks are quite difficult to manage when you have limited access to good water and sanitation. So I think we need to look and see from a community level, from a political level, actually really ensuring that we overcome these inequities in socials and problems that we face. But absolutely, hepatitis A and E is a fecal oral transmission, and hand washing is important to break those cycles of infection. But remembering hepatitis A, as we said, is vaccine preventable, and Mark has shown you how we're having these changing epidemiologies. Hepatitis E, there is a vaccine, but not freely available, although WHO has actually enable this to be used in the emerging situation. And Sudan, we have been really superb in how they've actually utilized that facility. And I think in very difficult circumstances, particularly that recent outbreak in Sudan, where in fact they were using canoes and speedboats to reach communities to actually vaccinate. So really, once again, I think emphasizing political will to actually overcome a problem. And so I think the next question was, I think you can ask Professor Al-Sayed, a question from Amonga Mida. Can colleagues in Egypt share the strategy they use to reduce the price of DAAs? Manal, over to you.
Yeah, thank you, Wendy. And I'm sorry I can't join by video as well due to internet problems. Just a few notes first on the hepatitis E and A. I think because of the shifting prevalence, there is also lack of diagnostics. For E, for example, we don't have diagnostics in Egypt, although it's a very big country, for hepatitis E, and therefore it's not diagnosed. And I think it's only diagnosed when you're having a certain project or a research study. Otherwise, the tests are inaccessible. The ELISA tests are inaccessible, not to mention the molecular testing, and it's extremely expensive if it's to be done in private labs. Similarly, I've just heard recently that the hepatitis A, although it was highly available, now it's not very much available as it used to be. And we're seeing shifting prevalence. We're seeing severe cholestatic hepatitis in people in their 30s. And we've had a couple of cases, very young, who've had fulminant hepatic failure and had a transplant. So I think we need more epidemiological data from our region on hepatitis A and E, on the genotypes and the behavior of the viruses, and I think that's also should be a priority, and I think it should be also a priority of WHO. For hepatitis C, of course, we were one of the first countries in the world to negotiate the price with a manufacturing company, the first company that manufactured the sofosbuvir, and that was because we had already the infrastructure ready. We knew the numbers. We had a registration system, so we were ready to start immediately and start and showcase a model program. So I think that was one of our leverages when we negotiated for the price and had it at 1% of its global price. But also at this negotiation, we did not allow for patency, and therefore we were allowed our local companies to manufacture the generic drugs. And once we started manufacturing our own generic drugs, we were completely independent, and we are relying on our own Egyptian manufactured drugs. And we started using them in the whole program, and became one over 1,000 of the global price. And that's how we could scale up and expand massively. And the generic drugs in Africa now are available for other African countries. For example, Egypt is pledging to treat more than 1 million Africans with hepatitis C. You have to apply to Ministry of Foreign Affairs, like most recently Ghana has done, and then you can access free medications coming from Egypt for treatment of hepatitis C.
Thanks, Manal. So the next question is from Chiobisi George, and I think this is for you, Professor Zutan. After initial treatment of hepatitis B in newly diagnosed individuals, the patient still is seropositive even 10 years after. Is this normal, and what should be done for this patient? So a patient with hepatitis B on treatment 10 years later is still hepatitis B surface antigen positive. Dr. George is asking, is this normal, and what should be done for this patient?
Yes, thank you for this question. This is commonly seen because the spontaneous healing is quite rare. We have it in some patients, but many ones, even if they are under treatment, after many years, they are still positive with the surface antigen. So the only thing to do is to continue to monitor him and to let him on treatment, to continue the treatment. And perhaps some years after he can heal and eliminate his hepatitis B virus. But when you still have this positivity, you must still continue the treatment and the monitoring.
Thanks, Professor Zutan. I mean, we do know now that there are functional trials for functional cure, but the problem is those trials are actually quite difficult to implement, and really we need to be looking within the continent of Africa how we can have access to those trials. But that's something for the future. But at the moment, as Professor Zutan says, it's lifelong therapy, and I think that's quite important that one actually emphasizes that when one initiates somebody on treatment and doesn't give sort of false security that is going to be a short-term therapy. We have a question now from Zimbabwe, Silungile Moyo. Now this is for you, Dr. Nadal. As a continent, we have started the elimination of mother-to-child transmission. When one tests hepatitis B positive, are we able to cater for all her contacts? So, I mean, as we're saying, we need to actually make the pregnant woman who's positive, we need to use that as the ability to actually screen partners, siblings, children. Are we capable of doing that?
That's an important question. I mean, we are able to do that. The test kits for surface antigen are readily available and are accessible, are affordable. We have, as a continent, been able to successfully implement routine HIV screening in pregnant women and have added on syphilis screening as well. So hepatitis B testing should be integrated along these in line with the WHO's triple elimination agenda. And subsequently, there's provision to provide prophylaxis for women in settings where additional testing like viral load and ENTN are not available. But when they're available, we should be able to do this to identify which women need prophylaxis. And linkage to care from antenatal settings is also feasible. And we have done a pilot study in the Gambia where out of 10,000 pregnant women screened from antenatal services, we're able to link more than 70% of them to care after delivery. So it requires a lot of follow-up and counseling, sensitization, and making the women aware of their needs, but it can be done. It is feasible.
Thanks, Shiva. Really sort of highlighting the point that the pregnant woman is the point of access to actually breaking cycles of infection within communities. The next question, I think, is probably for me. Curious to know this is from Flavia Mugisha. Curious to know the long-term effect of untreated hepatitis E. Is it as fatal as hepatitis B and hepatitis C if untreated? So I think the first thing to realize that for hepatitis E, the majority of infections are completely asymptomatic. we tend to be aware of hepatitis E when we have outbreaks and epidemics, and that's usually in the setting when one's had a breakdown of access to safe water and sanitation. And so and it's quite interesting. It seems to the clinical symptomatic cases seem to be more prevalent in men, in younger men, and it's usually a self-limiting disease like hepatitis A. The situations where there's a high mortality is in pregnant women, particularly during the second and third trimester, and that can have a mortality up to 25%. And unlike other liver diseases during pregnancy, where if you initiate delivery early, in fact, there's improved outcome, delivery doesn't actually prevent improved outcome for hepatitis E, and there's a high mortality associated with the unborn child as well. So usually it will be a self-limiting disease. There is a situation, as I mentioned, of chronic hepatitis E, and that's usually genotype 3 and 4, and that's usually in the setting of immunocompromised individuals. So transplant patients living with HIV who are not well-controlled, diabetics, they are more likely to potentially develop chronic hepatitis E, and that's really only been documented with genotype 3. I think what we underestimate, and that really depends on your access to the diagnostics, is if you have somebody presenting with acute hepatitis of high transaminases and jaundice, one really should be screening for hepatitis E, and preferentially with the hepatitis E RNA. So majority will be self-limiting. In fact, majority will be totally asymptomatic, but really patients with chronic liver disease or pregnant women and immunocompromised individuals are at higher risk. And then, Fumi, asking the difficult question. We will fund prophylaxis of testing for hepatitis B. This is a challenge and needs to be expressed. So maybe, Jibril, I'm going to put that in your corner. You've had a lot of experience in terms of the Prolifica, which is a research-based, how we take that out into the public arena.
Yes, and I highlighted this in my talk that access to prophylaxis is highly limited in many African countries, in the Gambia indeed. The Global Fund did announce, I think last year, that they would include prophylaxis for hepatitis B in their support for reducing viral hepatitis new infections. And this is one route that countries can apply. It is a procedure, but I mean, through that, I know countries can benefit from resources to procure test kits for antenatal screening for hepatitis B surface antigen and tenofovir monopill for prophylaxis. I know the Gambia did apply in the last round of Global Fund applications, and they would be rolling this out by the end of this year or sometime next year. But yes, we do need to find reliable solutions to providing continued access to prophylaxis and screening for all pregnant women.
Thanks, Jibril. Mark, before you leave, maybe you can give sort of insights how South Africa is approaching this.
In terms of access to screening, Wendy? Or?
Yes, so I mean, in terms of mothers to child screening, access.
Yeah, well, we seem to have taken a more staged approach in our neck of the woods. We've decided to start screening in pregnancy, and those who are surface antigen positive are then linked to birth dose and tenofovir, etc. So we're not going for a universal approach at this point, but clearly I think that's not a sustainable issue, because if your purpose is elimination, then this needs to be a universal approach. So I think we're probably going to get there in the not too distant future, where you just have universal birth dose vaccination. At the moment, in a sense, we're sectoralizing it. But I think it's a step towards universality, I would imagine, Wendy.
Thanks. Professor Zuton, maybe give your experiences and how one, is the access to screening? Is it out of pocket? Is it state funded?
Yes, here in Cameroon, we are trying to ask for support from the Ministry of Health. So, for example, for this World Hepatitis B to come, we got a lot of tests from the minister. So I think that our screening is going to increase around the country. I hope the minister is still going to continue this goodwill to help us.
Yeah, I mean,
I don't know from where they have their financial support to have all these tests, but the problem is that on the field we have them.
Yeah, I mean, I think that really highlights the thing. I mean, majority of us will have our national guidelines for hepatitis B, mother-to-child transmission. We now have the very easy to follow WHO 2024 guidelines. But I think ultimately one needs to have political commitment to actually implement, and one needs to have dedicated dedicated domestic financial funding to actually implement this. Professor Leslie, a comment from you?
Yes, please. You know, I think this is very exciting because the global report showed that we have all the tools. We've said it all. We have the strategies and the tool, yet countries are not scaling up. And there was something my colleague said now about South Africa and how South Africa is starting only with targeted approach to hepatitis B positive women, and then is likely to scale up. We must have a phased approach. We sometimes forget that even in Egypt, their mass screening was not the first approach. They had started by screening key populations and various other populations. They had a birth age cohort screening and had done the response to a certain stage before they transited to universal screening of everyone. So for many countries, we have to think of how do we begin a phased implementation. I'm from Nigeria with over 200 million people. There is no way the country is going to start screening everyone for B and C. So we need to devise an approach of what is our entry strategy for viral hepatitis. And I think the Global Fund, UNITAID, they only present an entry strategy. So we need to really think how. Micro-elimination is also an entry strategy. So a phased approach to implementation and examples is really needed to take us towards hepatitis elimination. So I just wanted to mention that.
Yeah, I mean, I think that's really important for me. I mean, often we paralyze because we can't put a whole program into place. Start small and build up, because unless you start, nothing is going to happen. And it can be potentially overwhelming for ministries of health to have a massive program that they have to implement. For me, this is probably another question for you from Eric Ilunga. What about the evaluation of the quality of diagnostics tests? I'm from the DR Congo, and we receive tests that come from everywhere, whose quality leaves something to be desired. I want to know which tests or brands have already been evaluated. So maybe just talk about the WHO pre-qualified tests.
Right. In the access report as well, it identifies some of these challenges, some of these quality challenges and cost challenges. There are several WHO pre-qualified hepatitis C kits, for rapid test kits for RNA. And of course, recently we have the HCV self-testing kit, which has received pre-qualification. At the same time, we have a little less hepatitis B surface antigen pre-qualified test kits. They are on the website. I can share them later. There are no pre-qualified rapid test kits for hepatitis A or hepatitis E. That is a challenge. And right now, we're even working to increase the pre-qualification for even the drugs, including the DAAs and the various formulations of tenofovir and TAF. So the WHO pre-qualification process is quite rigorous and intensive, and we're trying to encourage manufacturers to come forward with their products for pre-qualification, because that makes it easier for country registration. We note, however, also that some countries have their own processes. Right now for Africa, we have the African Medicines Agency, and they are looking at products in the Africa region with validation or certification in the Africa region so that countries can also come on board and register drugs that have been verified by this association. So there is action happening even at the Africa continental level that will really expand the toolkit we have for diagnostic and drugs. So thanks, Anuba.
Thanks very much, Fumi. So I think that really brings us up to 12 o'clock. I think we've had excellent presentations from all 5 regions and very importantly, important insights from Professor Leslie in terms of implementation, where we are, the role of WHO. And I think I really encourage you to look at that WHO 2024 Global Hepatitis Report. Actually answers many of the things in terms of access to diagnostics, access to genetics, where we are and what we need to, how we need to go forward. Remembering that public health approach, which is what we're going to have to actually embark on if we're going to address viral hepatitis within Africa. So thank you to all our presenters. Thank you to the behind the scenes people who managed to get this on the go. And then very importantly, to the participants who actually make this possible. I hope you've all learned and enjoyed it. And till next time, thank you very much.